All right, Gavriel Kohlberg again, and thanks to Dr. Backus and SOAR for inviting me to have this panel. I have no disclosures, and to our esteemed panelists. Wait, except somehow Dr. Babu got on there from last year, so sorry about that. Okay, here we go. So we're gonna just touch on a couple different medical office therapies on a range of topics from treating patulous eustachian tube dysfunction to otitis externa and in-office injections. And very much looking forward to hearing the treatment modalities from the panelists. So patulous eustachian tube dysfunction is, I find the patients some of the most distressed patients from a quality of life standpoint compared to the effects, like nobody's gonna die from their patulous eustachian tube dysfunction. It's not gonna progress to a terminal illness, and yet some of these patients can be just really extremely distraught by their symptoms. And so I'd like to just start with the panelists and see if we can, I'd love to hear from each of you kind of your approach to treatment, if any, that you provide in the office. And we can start with Dr. Briggs.
Sure. As you mentioned, the first thing that I treatment is counseling, often with these patients. So making sure that they realize that it's not life-threatening, letting them know that you understand it's annoying and it can be disconcerting to them, but knowing that no treatment is actually required for it. And then if you just do opt to have a treatment, then considering hypertonic saline or even like nasal estrogen or progesterone.
So true story. When I first started in practice, at the end of my day, one day I had a telehealth visit, and the person was calling from Edmonds, Washington, and it was a patient that had been searching, trying to find me for over a year to prescribe topical nasal estrogen. So I've done that a couple times. I believe in it. 25 milligrams of Premarin estrogen and 30 cc's of saline. You can send it to a compound pharmacy 3 times a day. I would always try that first.
In terms of patients that I've seen, reassurance, I think it's like one of the most important part. I think probably half of the people here today didn't see, but I do have an otoscope that I show them. And for a lot of these people, it's the first time they're seeing their ears, and I have them read them out. And when they see that feedback and understand that this is not like a life-threatening thing, because they're thinking, they bring up like, do I have a brain tumor that's moving in and out of my head? Having them visually see it, I've seen a lot of people just be more reassured in that standpoint. I also agree with Premarin. 2 smaller stories. I've had a patient that picked up smoking cigarettes to help out, and it worked for him. I did not advocate for that. And then I had a patient from China who went to like a naturopathic doctor there that gave him capsaicin nasal spray. I understand how that would work, but I understand that it's very spicy for their nose. So yeah, very interesting.
Yeah, I think just to reiterate a couple of the points is counseling, I think, is a major part of it. It really helps a lot if patients can watch. I do have the little endoscope that Juno was talking about, but in our clinic, we have it on a monitor. So it's very easy to demonstrate to a patient what they're experiencing, and again, really emphasize that medically it's not a concerning problem. In most cases, I think we'll talk about it in one of the other panels, that there are occasional cases where I treat it, but I don't tend to use the Premarin drops. So I usually mostly reassure the patient about what's going on, and that really it's not a medical problem in terms of complications. But if they do some of these other things that might actually compromise eustachian tube function, that becomes a medical problem. So to really emphasize that this is something they should be reassured, it shouldn't cause them any other issues.
Thanks. And so one thing that I also do is I try and take people off sort of decongestant medication as a trial. And I also recommend that they try the Patulin drops, which is another drop. I think it's basically a nasal irritant that they can buy online. So I give them the printout of the website, and I have them try that and the Premarin. Although we're focused on medical therapies, I'm just curious if anybody here does any surgical procedures for patulous eustachian tube dysfunction here in the room. Any hands? Yeah, Dr. Bojarab, Dr.
Well, if they're very bothered by it, and I don't see too many people that come in for the first time to see me.
Yeah.
They've already shopped around 3 or 4 or 5 $1,000, so they are distraught by it. Of course, we tried the counseling first of all, but there's a couple of different ways that you can try adjusting the eustachian tube. So one is the absorbable prolarin type of medicine. You can inject it in the torus back there, just a small subcutaneous, see if it helps them. And you can do that as an in-office procedure or in-hospital procedure. If that works, then I think we're going to address the eustachian tube. And what we did 20 years ago is that we would incise the posterior cushion endorally, and then we put a piece of cartilage in to just fill up the eustachian tube orifice, and that seems to help like 90+% of patients. I recently tried something that's in the Japanese literature where they take an angiocap, a 24-gauge angiocap, you raise an anterior tympanomeatal flap, you wrap fascia around the angiocap, and you put in the eustachian tube. And that worked for a couple of years for 2 of my patients, and now they're recurred, so I don't know what I'm going to do. But yeah, I address it if it's to that level with the patient.
Dr. John? Track.
Oh, yeah, so, yeah, I tried for a while. I also, when all the medical therapies would fail, I tried to also inject with like a radius force gel, like the short-acting kind. That'll give them relief for like 3 to 6 months, but a few patients I did it after a while, the body reabsorbs it very quickly, and then you basically have to go to more invasive things. Fortunately, I don't have a lot of those patients, but I've also tried to plug the eustachian tube from the middle ear side, either with fascia or with a little bit of bone wax, and then packed with fascia. And then I tell those patients, you're probably going to need a tube, and invariably they do. So that's the other treatment. I don't do cartilage graft augmentation of the torus. I know that some people do, and I don't do it because I think it's very difficult to gauge exactly how much cartilage, how much to fill and augment. And some of those patients, you'll basically end up causing the reverse, which is chronic eustachian tube dysfunction, and they need a ear tube.
Thank you. All right. So we're going to move on from that riveting topic to a mix of treatments. And so let's start with more of a presumed bacterial otitis externa with drainage. And there was a hope that we would kind of have a scintillating discussion on the different drops, powders, and irrigations, if any, that we use. And so maybe this time we could start with Dr. Hume and work our way back the other way. And then a follow-up question of when do you culture?
So I would say the first thing is really talking to the patient about what they're doing with their ears, with a lot of counseling about water exposure, any kind of physical irritation, cleaning with Q-tips or little endoscopes or whatever it is they're working on in their ears. And I think that's an amazing how many people don't realize that that washing their ears out is the reason they have the problem. So I think keeping their ears dry. So I usually start with that, and then as sort of a probably partly placebo and partly water protective, I have them use some olive oil or mineral oil as kind of a preventive thing. And then if things progress, we can pass it down. But I mean, I think powders can be helpful for some people. Some people like to use acetic acid drops, or acetic acid alcohol can be helpful. It can be kind of irritating to some people, and then they can get some sort of eczema or exacerbation of problems with the skin. So I think being minimalistic at the start is good. I hardly ever irrigate ears, and I would say I rarely culture unless they're people that have other systemic illness and have been on prolonged antibiotics. You're concerned about skull-base osteo or something.
Yeah, I think, is this also? Yeah. In terms of like, I think recalcitrant otorrhea can be very, very difficult. I counsel the patients. In training, we didn't use any powders at Emory and Dr. Backus. We try to go really conservatively at the beginning. I was not a believer of the acetic acid, rubbing alcohol mixture, but these patients get better. I think the acidification and getting their pH lower to its natural state has really helped out with a lot of these patients. And then I think I always counsel them like, hey, this is going to be a long problem. We can work on this. So I do have patients come back at, depending on how bad their otorrhea is, at regular frequency, so we can do oral hygiene. I think that's really important to just keep it clean for as long as we can.
Yeah, I agree. Bacterial, I usually just do ofloxacin drops. I really never prescribe Ciprodex. It's expensive and people have to pay for that. I'm a big believer in alcohol and vinegar. I just tell them to buy your white vinegar in your cupboard and rubbing alcohol 70%, mix it together, rinse your ear. I think lowering the pH helps. I would say don't forget fungal. If you're stumped and you can't figure it out, fill the ear canal with Lotrozone ointment and suck out the lumen of it. That oftentimes helps as well.
And for me, I'd say for acute, I agree, ofloxacin drops. If they fail acute therapies, then I will actually culture at that point, make sure that I know what I'm treating. As they progress to more of a recalcitrant picture, I like gentian violet. It works pretty well, so I actually do a topical gentian violet and follow it with the boric acid powder. If they happen to fail that, which is exceptionally rare, then I'll do a CSF powder.
And how does that rubbing alcohol work well with the TM perforation, or would you? No. Yeah, okay.
If the drum's not intact, I would not do that. If it's small, sometimes I have them do it against gravity, though, if you need to.
Okay. So let's move on to fungal, and here I'd love to hear, we got a little bit of a hint of some fungal therapy, but in particular, I think something that comes up a lot is, well, what do you do if there's a tympanic membrane perforation, and how do you manage that fungal infection with a tympanic membrane that's not intact?
Yeah, for me, again, it's oral toilet and dry ear precautions, making sure the patients understand that that's really what's the most critical aspect of curing their disease. If they use hearing aids, making sure they stop using the hearing aid in that ear for a period of time. Also make sure they understand the importance of hearing aid hygiene. I've noticed recently a lot of patients aren't educated in that, and the audiologists, for some reason, the past 5-10 years haven't been teaching patients a lot about that. So making sure they understand how to care for their hearing aids so they're not seeding their ears with fungus. If there is a perforation, again, I love gentian violet, I love boric acid. It's not painful to the patient and it works really well.
Any other tricks for that fungal infection with a tympanic membrane perforation that somebody care to share?
We've got to be careful that this is not caused by overuse of antibiotics. What is the cause of it to start with? Sometimes you can get really peculiar sensations and pain with fungal things. So you've got a dry fungal infection with what the classical spores, and you've got a wet, manky, cotton woolly debris you just got to do oral toilet on. I'm sorry I had to take a call from Malawi, but going back to topical drops, vinegar and povidone-iodine, diluted povidone-iodine, we have a spray called Ear Calm. Do you have Otamize antibiotic over here? It's like dexamethasone with neomycin, and the vehicle, the liquid of Otamize is basically vinegar. So again, it's well known for years from the Egyptians who used to pour urine into people's ears. So it's just changing milieu of the toilet. So we have a thing called Otacomb, which is, I call it our local domestic. It's triamcinolone, gramamycin, there's antifungals, there's everything like that. So a good old wick, leave it in, let all the goo come out, and then you titrate the toileting to whatever you need, and water precautions. And I would certainly second, keep your hearing aid molds clean, or go to the situation of using bone conduction, like Adhere or something like that, just to get you out of the acoustic hearing aid.
I'd say another challenge I think we sometimes have is there are patients that, for whatever reason, because of a small ear canal or maybe some problems with dexterity and so forth, putting the drops in, that they're really never getting the drops in anyway. And so I think sometimes for those folks, cleaning them out really well in clinic, and somebody already mentioned ointment, but a lot of times what I'll do is just fill the canal kind of like a lasagna, layers of nystatin and mupirocin ointment, and just fill the whole ear canal. I don't suck any of it out because and I use the ointment, not the cream, so it is also sort of stays in longer and doesn't tend to get diluted by water. And then have them come in every couple of weeks, and it's amazing. Some ears that you've struggled with for drops, which basically we're never getting in their ear canal, That's enough to kind of get them over that first step. And then you can kind of gradually transition to some of the more conservative things like putting some powder in or something else as sort of a dry preparation. Because I think part of the challenge is when you're putting any kind of drops in there, sometimes the drops themselves, whether it's promoting a fungal thing or just the moisture, is part of the problem. So trying to get away from moist preparation, I think, can be helpful too.
Gavin, the other thing I would add is sometimes if it's really bad, just doing oral diflucan, 100 milligrams BID for 10 days helps too.
All right. So now let's move on to the topic of tympanostomy tube and myrigotomy. And for this, let's focus on maybe a patient with sort of some level of obstructive eustachian tube dysfunction symptoms. So when do you put a tube in? When do you do a myrigotomy? What are your thresholds? What's the conversation that you have with the patient? We start with you, Dr. Briggs.
Unless it's a hot mastoid in the ED, I never just do a myrigotomy. I've just, in my experience, you make a myrigotomy, even if it's for an acute, middle ear effusion, it heals and it reaccumulates and they're back in your office in a week or two. And so I just counsel them that, tympanostomy tube, it remains intact for, 6 to 18 months. It falls out on its own. It allows your ear to heal, and then come back and see me, and we'll address it once it falls out and see if it reoccurs. But yeah, I almost never.
The spiel I give, so I explain eustachian tube dysfunction to the patient. I say on one end of the spectrum is conservative management, easy things, nasal sprays, things like that. On the aggressive end, we can put you to sleep, put a cartilage-embedded T-tube. Somewhere in the middle is an in-office balloon or an in-office tube. And I say, my job's not to tell you, you tell me what do you want to do.
Yeah, very similar management with Jeff. I think a lot of it is dependent on just like how frequent their symptoms are and how distraught they are. I think moving from Georgia to Seattle, I didn't realize how much like barometric pressure differences will bother these patients. And it was like in the summer when the wildfire was happening, I had so many patients come in with obstructive eustachian tube dysfunction, and most of them were very happy with just doing conservative management. And then now in like the winter time, there's like another flow of people with similar symptoms. So a lot of it is, in terms of timing, dependent on how their symptoms are, whether it's very chronic or not.
Yeah, I don't think I have much to add. Rarely do a myrigotomy except in the severe acute setting in the ER kind of thing. And then progression, depending on how frequent they've had symptoms. Is this recurrent eustachian tube dysfunction over decades, or is it one event after a upper respiratory infection? And then sort of discussing the continuum of things to try, from really conservative medications, waiting, auto-insufflation kind of stuff, or putting in a temporary tube to start, and then progressing if they've needed multiple tubes to other options.
We're assuming we're not dealing with children here.
Not dealing with children.
Just
Yeah.
adult. So the unilateral fluid in an adult, you need really to make sure there's nothing in the postnasal space. So proper endoscopy of that, even to the extent of doing a CT or an MRI. But you get a gut feeling of what you need. And it depends on what the patient's complaining of. If it's purely because of the hearing, and from a duration point of view, use probably the adage of what you do in a child, give it a few weeks, 2 or 3 months before any intervention, if this is the first stage, and if need be, under some Emla cream, just do it in the outpatients, put a simple tube in first, but if there's a degree of atelectasis, put a collar button, trying to put in what's called T-tube. Do you have pearly tubes, the little goody T-tubes to put in? They can be a little bit more uncomfortable unless there is reasonable middle ear space, but if you've got the atelectic one, you might need to do it to a general anesthetic.
I think it was mentioned earlier too, a question about post-radiation to the nasopharynx. I recommend being really cautious with those patients because sometimes you can put a tube in there, and what you do is you go from an ear with a conductive hearing loss where they can wear a hearing aid to an ear with chronic otorrhea that never heals.
Yeah.
So post-radiation, I recommend being very, very conservative, and I have a long discussion with a patient before I agree to put a tube in, because you often start with something which is annoying to something that's really a major problem for them. So I would be very cautious about tubes and post-radiation. Not that I don't have some patients that have them, they don't have otorrhea, and they do great, and they're very happy with them, but I think you have to be very careful with those folks.
So, for me, I find that the patients with eustachian tube dysfunction who are the happiest with the tube are, business people who are flying for business like weekly who have severe pain with the flights. And those people are just so happy to have a tube because they now are pain-free, and they're willing to deal with any small symptom related to an ear tube on a day-to-day basis. And then the people who are the least happy are the ones who you put the ear tube in and they immediately tell you that the pressure sensation has now gotten worse. So I'm curious from the panel or from the audience if there's anybody who does a myringotomy for that to try and get a sense if they want to have a short-term experience with it. That's a couple people out. So.
Yeah, we just had a patient that Dr. Backus put in a tube, felt great, like for 30 minutes, came back a week later, he was like, I want the tube out. He's like, I feel even better now, so that's hard to say.
Yep. Dr. Rozak?
Yeah, I mean, that's something that all of us generally in the team, you see it every week, right? You see patients that say, my ear is pressurized, it's full, it's been like that. You're not sure if it's cochlear hydrops, kind of symptom of the hearing loss. So is it middle ear, is it intracochlear? So what I do is I do an anterior myringotomy. And I just take a myringotomy blade and I put it in the ear, I twist the blade so it just has an opening. And if you hear a snap, those patients, they're going to love having a tube. If you do it, they immediately say, I can't hear now. So I just put a paper patch and say it's not eustachian tube. So we have, there's also tubes that last 3 weeks, tubes that last 3 years, so there's a whole spectrum of tubes. We have pediatric triune tubes. So they're really tiny, they're made out of plastic, they're 0.75 millimeters in diameter. So those last 3 to 6 weeks. So I do that with patients that are going to be flying, or they're going to Europe and they just don't want to have to worry about it. So there's tubes that last weeks and tubes that last years. So I determine that I'm going to put a tiny Titan type tube that lasts 4 months, or you're going to use a T-tube. And then there's different T-tubes too. There's 280 different tubes on the market. So you have 3 or 4 in your office, kind of different reasons.
Thank you. All right. We're now going to move on to steroid injections. So I think sudden hearing loss would be the classic indication. A couple questions I have for the panelists is, and maybe we can start with Dr. Briggs, and then if somebody has something very different that they can do, they could share. But when in your in a patient without like a severe diabetes comorbidity, so somebody who could get oral steroids, you started on that. So when do you start thinking about steroid injections?
So in general, when I meet a patient who has a sudden sensorineural hearing loss that has a confirmed sudden sensorineural hearing loss by audiometric criteria, I counsel them about all the options that are available according to, again, I practice largely guideline-based. So according to the American Academy of Otolaryngology, head and neck surgery guidelines, you can counsel the patient about oral steroids. You can counsel them about intratympanic steroids, particularly for recovery after 2 weeks of failure or failure of oral steroids. And then you can also give them the option of hyperbaric oxygen therapy. So those are the things that I kind of talk to patients about initially. Most patients in my practice will opt to try the oral steroids because it's less invasive, and so we'll do a course of oral steroids for a week or two, have them come back and have a repeat audiogram. And if their hearing has not recovered at that time, then we'll consider doing intratympanic steroid injection. But as was mentioned earlier, I do allow the patients to have the freedom to make that decision. So if someone really wants to advocate for having it initially, I will offer it to them initially, but most often I suggest following the guidelines of oral steroids for about 2 weeks and then repeat audiogram and then using the injections for recalcitrant.
Any other comments on when to initiate that steroid injection from the rest of the panelists?
I'm pretty aggressive, I would say. I always give the option, but I usually do, if I'm going to do it, 3 injections within a 2-week time period. They just come back and I ask them, are you better? Usually they know if they're better. We get an audiogram to prove it. If not, we just offer the 2nd and 3rd injection.
So there's a clinical study going on in the UK at the present time because, there's a clinical study going on. If you look at the NICE guidelines on adult hearing management, it's 550 pages, And one of the issues is, are you treating, is the doctor treating himself or treating the patient regarding steroids? I think we all have in our hearts that steroids help. So oral steroids tends to be the first line of action from my point of view. And if there's no response, to offer them intratympanic, but up to about an 8-week window. But a lot of our patients, there is a delay in presentation because they sometimes don't have any symptoms, they just feel it's a bit funny, they don't, they may not get an appointment with their doctor, don't go to casualty, the casualty guy doesn't really understand the difference between otitis media and a sudden sensory neural hearing loss because of the so-called hearing problem. Go and see your doctor, and it gets a caveat, it goes round in circles. So I think the definition is up to 90 days of a sudden 3-frequency loss of 30 decibels within that period. And it's a question then of when and how long do you do it for. I think after about 8 weeks, if things haven't improved, we probably wouldn't give some steroids after that time. But again, there's plenty of case studies to indicate that steroids help, but I think there's 50 or 60% of patients tend to get better. But the other thing is, how bad is the hearing loss to start with? So there's various clinical indications of what you'd expect people to get better from. But the more profound the loss is, the worse the outcome tends to be.
Yeah, I like just setting expectations that it might not work, but it's the best shot we have. I like to tell them that, from the Academy, all the clinical practice guidelines has a patient executive summary section that I actually print out the one for sudden sensory neural hearing loss. I have a pile of it in our clinic because a lot of these patients are very distraught that they're losing the hearing loss, and just giving them that 2-page summary and just kind of going through with them is really helpful.
What do you guys counsel? What percentage do you give to your patients if you start steroid therapy within a certain amount of time frame? What's your percentage of recovery? Does anyone give a number?
Dealing with what level of hearing loss?
I would ask,
If
does
it-
that change your answer? In
I think
any
if
way?
it's profound, I mean, if it's worse than 70 decibels, I think the chance of getting recovery or functional recovery is going to be low.
Profound with vertigo is even worse.
Yeah, other symptoms, yeah.
Right. Yeah. So there's plenty of data that if you have a mild hearing loss, the chance of recovery is like 75-80% if you do nothing.
Yep.
Or you treat it. And then the worse the hearing loss, the worse the recovery of natural recovery. But I'm questioning why hesitate, if you're going to start oral steroids, why hesitate the intratympanic steroids? Are we worried about complications of doing that? Because it seems to me if we think steroids help, why not give the highest concentration to begin with? And isn't there a time where if you wait the 8 weeks or 10 weeks or 12 weeks, is there any data that steroid intratympanic helps when you're giving it that late? I always approach things just like Bell's palsy. You want to give steroids right away, and you give it 24 hours a day, 7 days a week for the 10 days. And you don't want to have much slow-up period. So you want the concentration of steroids to be relatively high.
I think some of the issues you get is who's going to do the prescribing for that. If it's done by primary care or the casualty, they don't have the expertise to do intratympanic, and then they have to refer them in. So yes, in our ENT clinic, we would offer oral steroids versus intratympanic, and a few people don't really want the idea of having an invasive procedure done to them. It's
But if
not.
they say it's okay, I don't mind.
Oh yeah, we'd do it. Yes, do a spinal needle, and some of my colleagues do it under a bit of local anaesthetic. Others don't, just pop it in and inject it.
For me, it's if they're going to recover without it, then you're subjecting the patient to the risk of a perforation and then potentially a need for another procedure without necessity. So that's why I give them the oral steroids for a period of time, see if they recover without it. And if you've saved a whole population of patients from having intratympanic steroids, a procedure, returning to your clinic repeatedly for injections. I mean, in my patient population, for them, sometimes it's hard for them to get off of work. So you're looking at not just treating them, recovering of their hearing, but also the global patient taking PTO, missing work.
Is hyperbaric oxygen covered where you practice?
It depends on your payer. So some of our private payers do cover hyperbaric oxygen, and we usually do that for patients who have failed oral steroids and intratympanic steroids within the first 3 months of having loss.
Dr. Bojab, just to go off what you say, I actually agree with you. I do the same thing. I tell people there's no data to support that oral and IT together provide better outcomes, but honestly, if it was my year, I would probably do both. That's what I say.
We're also doing hyperbaric now. What I've done is I've consulted the hyperbaric chamber near us, and we've worked out a price. So we can get 3 weeks of dives, 5 days, so 15 dives for $2,000. So the patient wants maximum therapy, they're going to have to pay $2,000 to this hyperbaric center, and they'll do that at the same time. But trying to get coverage from our insurance carriers in Michigan is very difficult. Some can submit it, after the fact, but it's hard to get coverage, and I kind of leave that up to the patient. But I want as much steroid as quickly as possible, because if you look at histologically, we only have the histology of people that have had car accidents after sudden hearing loss. Fibrosis occurs really quickly. You get cochlear fibrosis like in days. So if I see a patient at 8 to 10 weeks, I don't offer anything, because that ear, it's already set the course. So I don't know. I tried sudden hearing loss in Michigan ear is an emergency. So when someone comes in with sudden hearing loss, we see them that day. We don't make them wait 2 weeks, 5 weeks. We see them that day. We want to treat ASCP. Sudden hearing loss and nosebleeds.
So if a patient comes in at, say, 2 weeks, would you do oral steroids and injection on that first visit?
At 2 weeks.
Yeah.
I won't do it at 4 weeks.
Yeah.
Is there any good data with hyperbaric oxygen or with simultaneous use of steroids, injectable and?
Dr. Backus?
Have you seen increased benefit with hyperbaric?
If you look at I work really closely with our hyperbaric partners, and if you look at the data, it's supposedly 1 in 5 patients will experience some benefit from hyperbaric oxygen therapy. And so,
What is the definition of actually getting better?
recovery of hearing. What's that?
Is it worth 15 days to dive? Have you seen benefit?
Yeah.
Yeah, I have to tell you, I'm not a big believer, but some patients, it's a major, you have attorneys in your practice, you have salespeople, unilateral hearing loss is a major thing.
Yeah.
So we have not done a study, but at the academy level, they said there may be some suggestion of benefit.
Yeah.
From all the studies that they've done.
And that's why it's part of their guidelines as an option.
Randy?
So this is outside of the guidelines, but does anyone have any experience with doing research for N-acetylcysteine combination? There's very little evidence, but there was 2 studies that I looked at that were older and they're very small studies, but one looked at N-acetylcysteine versus oral steroids. They said the hearing loss recoveries were similar. The other study looked at combination of N-acetylcysteine with oral steroids versus oral steroids. So they did the recovery rate was double. I would love to see a good high-level study with a lot of patients to see is that valid or not. For patients that are not candidates, for patients that may be poor candidates for oral steroids, I also think along the lines of, if it was my year, what would I want done? So I tend to be more aggressive with that too. But anyway, that's just a question for N-acetylcysteine, if anyone has any thoughts on that.
Dr. Hume, can you answer that one?
Yeah, sure. So I used to make, obviously we do it in clinic. I used to anesthetize the drum in 2 different places with a small amount of phenol and have one sort of vent hole. But what I've kind of gradually progressed to is making a single hole with at least basically the minimal amount of phenol that I can use to make a little spot on the drum, essentially over the round window. And I usually use a needle to make the opening and use a 20 gauge micro tip just because it gives a little more room for visualization, and try to pre-warm. We usually if we can get 24 milligrams of Decadron, we use that. It seems like we have availability problems probably at least every other month. We get a notification we can't get it. So if I don't have 24, then I use 10 of Decadron. And very slow injection, basically warn them. Sometimes people don't notice the sensation at all. Other times people find it very painful. So I don't think I haven't figured out a way to predict how they're going to respond to it. I know some people do it without anesthetizing the drum, but I think if you use a very small amount of phenol, I think the risk is pretty low. Leaving a perforation makes it a little bit less painful. So, and then I just have them lay there, try to minimize swallowing, have somebody with them often, but don't try them not to talk. Try to minimize any sort of pumping to clear the medication, and then have them stay here for 30 minutes. And then usually I just put a cotton ball in their ear and have the medical assistant tell them they can go. Come back in a week, test their hearing, kind of see how they're doing, see if there's any change in the hearing, and decide if they want to go through another injection or not. I think which people already kind of mentioned it, but I think we're often treating people who don't even meet the strict criteria for sudden hearing loss. But for them, that change in hearing can be very profound. And so I think a lot of that is really counseling about what their expectations are for the recovery. And obviously if they have a profound hearing loss with vertigo, they have a very low risk of recovery. But sometimes their thresholds haven't changed that much, but their word recognition has gotten worse. And for them, that can be a huge thing. So even in those patients, I would potentially consider treating them for a sudden hearing loss, even though they wouldn't meet the strict guidelines. So I think it has to be an ongoing discussion with the patient.
So the other thing too, Cliff, to your point, is when you put this, we use Decadron. Sometimes that stings in the middle ear. So always warn them. And as Juno can tell you, we have them hold the vial in their hand, just so it warms up while they're waiting for you in the room. And so if you're really behind in clinic, just tell them they're warming their medicine. It buys you some time. But if you put it in too hot or too cold, they spin, and it's almost a big conversation to get them to take their second shot a week later if they're miserable from vertigo.
Dr. Briggs?
I was just going to say that was a great point that you make, that sometimes you can take a patient from being non-serviceable to serviceable. So, we look at, are we curing the hearing completely, or is their hearing coming back to baseline? But sometimes we should actually consider, are we just taking somebody from a 0% speech discrimination score to like a 70%? So at least they have a serviceable hearing. And I agree with your technique for injection. The only difference that I do is I do an anterior-inferior injection versus over the round window, because in my experience, when you do it over the round window, it tends to back out. And so if you do it anteriorly, it'll fall down and your meniscus will cover the round window, but you don't have to worry about the medication coming back out in your laryngotomy.
Quick question. What do we think about in like a profoundly lost ear to put a tympanostomy tube in and give them Pred Forte drops and say, hey, 10 drops 2 times a day for the next 14 days? Any thoughts?
Now you're going to cause
Yeah.
Yeah, but if an ear is that bad, what do you have to lose?
perforation. I mean, that was what, Herb Silverstein had the Silverstein tube, you put a tube and it had a wick in it. A lot of those ended up with perforation. So I probably wouldn't strongly recommend that, just because you're putting steroid around a perforation with a big tube in it, because you have to have you can't put a 0.75, like a tiny Titan tube, and expect fluid to get through that. So you're going to put a larger tube. And I do think you have a risk of steroid around a tube, around a perforation. So now we've elevated the problem. So I personally don't do that, but it depends on the patient too, how distraught they are. I mean, some people are very upset. So we throw everything at them up to about 4 weeks. And I think the chance of permanent perforation with your needle is pretty darn low. We actually put 2 holes in the eardrum at MEI. We do one anterosuperiorly and one posteriorly, right above the round window. And the reason we do that, it's like emptying a Coke can. If you have 2 openings, it tends to not fizzle out as much. So we have 2 openings, and hopefully air escapes through one and fluid won't escape out of the other. But they're just little stab incisions, and I don't think I've never had to repair a tympanic membrane after that. They all heal.
I want to thank everybody for participating, the panelists and the audience. Great questions, and to Dr. Backus and SOAR again for the invitation. Really appreciate it.